Next up, a panel of Alzheimer's experts is here to discuss innovations and advancements in science and their impacts on patients and caregivers. Julia Manchester, our national political reporter, is here to speak with them. Julia, take it away.
Thank you, Bob. Dr. Anna Burke is the Karsten Solheim Chair for Dementia and Medical Director of the Alzheimer's and Memory Disorders Program at the Barrow Neurological Institute in Arizona. Ian Kremer is the Executive Director of Leaders Engaged on Alzheimer's Disease and the LEAD Coalition. And Dr. Sean Tunis is a Senior Fellow at Tufts Center for Evaluation of Value and Risk in Health. Dr. Tunis was also an FDA advisor and former CMS Chief Medical Officer. Welcome to our panel. Thanks for joining us.
Thank you.
Thank you.
Yeah, Ian, I would love to start with you when it comes to the science on Alzheimer's. Where are we on, Alzheimer's and the progress we've made, and essentially, where do we go from here?
Well, it's been remarkable progress. Long and slow in coming, but we are here. When I started doing this work professionally more than a quarter of a century ago, all we could do for families and individuals was try to educate them about how to cope with a fatal disease, an irreversible degenerative disease that was certain to claim their life and diminish their quality of life throughout the journey. Starting 2 years ago, that began to change in terms of the science. It has not yet begun to change in terms of clinical opportunities, largely because CMS has stood in the way. It is remarkable how far this science has advanced so quickly. Now we have to do the hard work of getting this into the hands of clinicians and their patients so that people can benefit from the science that has emerged from decades of work to create for the first time ever an opportunity to slow the progression of the disease in its earliest stages. This is not a cure. I want to be very clear. This is not a cure, but these first generation medications that have become available within the last year or two, FDA approved, that is going to be a godsend for hundreds of thousands of families across this country if Medicare allows it.
And Sean, I want to get into that point Ian mentioned on CMS and their role in all of this. They're wielding a policy known as Coverage with Evidence Development, or CED. The idea was to have CMS cover those medical technologies in which research data was still being collected. But I'm wondering if you can answer, by subjecting Alzheimer's treatments to CED, does this move into question the FDA's scientific judgment, and will it restrict patients' access to those treatments down the road?
Yeah, so I think the Medicare's current policy on this class of drugs was heavily driven by the aducanumab decision and the data on aducanumab, which I think a lot of people would agree was. The FDA was looking at one positive trial, one negative trial. At a minimum, there was a lot of controversy. There were some advisory committee members who resigned because they were unhappy with the approval. So the policy that we have in place now is certainly quite restrictive in terms of access to aducanumab, but I think there's legitimate questions, clinical and scientific questions about whether that drug actually has significant effects. And particularly in terms of any cognitive improvement. Other panelists may have different views. I think the real issue now comes down to that at the same time that they restricted the use of aducanumab to randomized trials, they also said that for fully approved drugs or traditionally approved drugs with direct evidence of cognitive benefit, there would still be a data collection requirement under CED. And I think that's sort of going beyond where CMS has ever gone before with a fully approved drug for its on-label use. And so the access to the drug that many people have been talking about today really then comes down to how challenging is the data collection that CMS expects. And we can go more into that later, but it's basically patient access now comes down to how difficult it is to collect the additional data under CED that the current Medicare policy requires.
And Dr. Burke, I want to pivot towards a point you've made in the past, saying that there are essentially too few Alzheimer's specialists that can only cover 10% of people suffering from the disease, and that most of the care is being done with primary care physicians, who aren't necessarily well versed in the field and not able to handle the load of Alzheimer's patients. Talk about why it's so important to get an Alzheimer's patient in to be treated early on, and how it impacts, their lives living with the disease going forward.
Well, I think as we look at these new medications coming onto the market, we have to consider that these medications are most effective for individuals who are in the very early stages of Alzheimer's disease. So we're talking about the mild cognitive impairment to the mild dementia stages. If we are to give people access to these therapies, we need to identify them early. And that means we need to give our colleagues in the primary care setting, who see 90%, if not more, of these patients, access to ways of identifying these individuals, tools to help them manage these individuals. Oftentimes, they know that they have these individuals in their practice, but they don't want to open up Pandora's box and diagnose early, because they are afraid that they won't be able to support the patient and the family during the course of their illness. Identifying these patients early will not only give them access to these new treatments, but also, give them access to clinical trials that may help not only them, but society, and help them stay healthier longer. Help them maintain their brain health and their quality of life, particularly in those early stages when they can still continue to live their lives well. It will, as some of my colleagues also mentioned, reduce hospitalizations, emergency room visits. It will have an impact on our healthcare system as a whole, both in the quality of the patients' and caregivers' lives, but also financially.
Yeah, and Dr. Burke, that was actually just what I was about to ask you as well. How does this sort of lift the burden on the healthcare system, down the road? Obviously, in the immediate future, I could see it lifting the burden and helping hospitalizations, like you said, doctors, improving that quality of care. But down the road, maybe 5-10 years from now, what could this do? What kind of impact could we see in the long term?
Well, I think everybody is focusing on the cost of the medications right now, right? These are not cheap therapies. However, we do know that individuals with cognitive impairment, compared to their counterparts who do not have cognitive impairment, but perhaps have the same chronic illnesses, the same comorbidities, the people who have cognitive impairment are 300% more expensive to a healthcare system than those non-cognitively impaired counterparts. And that's because they are in and out of emergency rooms. They are forgetting to manage their medical conditions appropriately, forgetting medications and so on. It has a huge impact on their quality of life. We know that also there have to be individuals who care for them, right? So for the most part, these caregivers are under a great deal of stress and caregiver burden as well, which means stress-related ailments, which means anxiety, depression, heart disease. So we're impacting the system in that way. They're oftentimes having to take time off to care for their loved ones. So that's impacting their productivity in the community and in the workforce. And it is important to note that this unfortunately affects women far more than the rest of the population. About 2/3 of patients are actually women. And about 2/3 of caregivers for individuals with cognitive impairment are also women. So this has a huge impact on our society. If we can perform earlier diagnoses, if we can move into additional capabilities and supports into the primary care space to compensate for some of those perhaps limitations that we have as far as specialty services, we may be able to reduce those burdens, keep people living that good part of their life much longer.
And you do a lot of great work with the LEAD Coalition, which is focusing on access to treatments. What are the current roadblocks? We heard Dr. Burke talk about costs, but what other roadblocks are patients and, even others in healthcare, providers and such facing when it comes to obtaining those medications?
Right, and thank you for that question. It's really spot on, and part of our work is access to treatments, but it really is more holistic. We are trying to improve quality of life for everybody who is facing any form of dementia and reduce the risk of dementia, have fewer people struggle with these battles. There are so many opportunities to do better. Dr. Burke is spot on, exactly right, that if we can get radically better at early detection and diagnosis, we can vastly improve quality of life for people who do wind up getting dementia, but also for the people in their ecosystem. And we can reduce pressures on the entire health system for the benefit of people who are living with dementia and their care partners, their family members, but for all the rest of us as well. Just reduce stress on the system. Part of how you do better at detection and diagnosis is, again, have CMS follow appropriate policy. CMS has had in place for nearly a decade now this same CED mechanism, remarkably restricting access to PET imaging to detect Alzheimer's disease and do a differential diagnosis between Alzheimer's disease and other diseases and conditions that can cause dementia. That's been in place for nearly a decade, slowing down access for providers and their patients who could benefit. And there's no indication of when CMS is going to review that policy or lift that policy. That's going to create barriers to access for both lecanemab, the drug that was approved in January by the FDA, and the next drug in line, donanemab, that is going to be reviewed, we think, later this year by FDA. If those two drugs are available in terms of FDA approval, but are not available because CMS is still withholding coverage for the vast majority of Americans for the drug, but also withholding coverage for the vast majority of Americans to get diagnosed with the latest and best tools for definitive diagnosis, that's an enormous barrier. And I just want to make one more point about detection and diagnosis. We have brilliant, dedicated, overworked dementia clinical experts who are capable of making a diagnosis when the right tools are in their hands. But we force them unnecessarily to rely on what we call clinical observation, to make a very well-educated but really best guess about whether someone has dementia. We need to put in their hands the tools like PET imaging and blood biomarkers that are coming forward, hopefully within the next couple of years, to have more objective tools, more accurate tools to get at whether people should or should not be on these treatments.
And Dr. Tunis, you used to work, at the CMS and the FDA. What ripple effects do you think these decisions on Alzheimer's drugs, related to CED, may have on these institutions, mainly the CMS and the FDA?
Yeah, I think there's I think it could have some positive effects, but I do think that there needs to be some, you could either call them tweaks or significant changes to Medicare's current policy. The original intent of this coverage with evidence development, which started in the early 2000s, was to allow for earlier access to promising technologies while important unanswered questions were addressed. And I think, and everybody benefits from answering questions that can't necessarily be answered at the time of initial regulatory approval. For example, the benefits and risks, particularly safety in broad community practice, isn't known at the time of regulatory approval. The benefits and risks in different patient subpopulations isn't known. So those are important questions. The key is you have to be able to get additional data on those questions without creating huge restrictions or significant restrictions to the therapies that are either promising or extremely promising, depending on how you characterize the evidence on lecanemab and donanemab. So, What I hope this precipitates in terms of a positive effect in terms of FDA and CMS is jointly recognizing that there are gaps in knowledge that need to be addressed post-approval, post-access, and really becoming more energized in building the kind of learning systems, or what Rob Califf calls evidence-ready infrastructure, so that you can generate the evidence to answer these questions without this kind of crude requirement for people to enroll in registries and have neurologists try to collect additional data in the context of clinical care. I think if we get creative about how we essentially rely more on data that is passively generated while patients are cared for, we can have both access and evidence. And I do think that this difficult challenge around these Alzheimer's drugs will hopefully raise the level of motivation to kind of build that capacity.
Absolutely. And we only have a few minutes left, so I want to make sure we get to an audience question from Rick Pumo. He is the owner at Illinois Health Insurance Services. And Rick asks, does the cost of approving drug treatments for all existing Medicare members outweigh the benefits of treating them as early as possible? What is the value in mitigating the long-term care crisis we are entering? I'll throw it to all three of you just because we have a few minutes left. Dr. Burke, we can start with you.
Well, the value of identifying these patients early, I think basically this will outweigh any potential costs. Identifying individuals in those very, very early stages of illness, opening up the possibility of care with these agents at very early stages will allow patients to remain in those mild cognitive impairment stages, hopefully for a few years longer, meaning it will delay, for instance, the progression to the advanced stages and the need for placement in a long-term care facility. So I think in the long term, while it may seem expensive, in the long term, we will be saving some money on the tail end, not to mention, again, improving the quality of patients' lives.
And Ian, I want to throw that question to you as well, and then Dr. Tunis.
Sure. I think it is incontrovertibly worth it to make these investments in improving quality of life through better medication and earlier detection and diagnosis, as Dr. Burke has rightly pointed out. Incontrovertibly worth it. And overwhelmingly worth it. And here's why. Any family, and there have been literally tens of millions of American families who've been through this ordeal of Alzheimer's disease or other forms of dementia, any one of those families can tell you stories not only about the physical and emotional and spiritual toll it takes, but to Dr. Burke's point and to the questioner's point, the fiscal toll on the family, on the community, and on the government. We have to do this. And let me also be very clear about this next point. CMS does not have legal authority. In fact, explicitly, the law says CMS may not consider cost in deciding whether or not to cover FDA-approved drugs. It is off the table, and that's as it should be. I want to make one last point about cost, because there's been a lot of attention paid to the cost of these Alzheimer's medications. So compartmentalizing for a moment, the point about, is it worth it to us as individual taxpayers? Is it worth it to us as individual families? And is it worth it to those of us who live with these diseases day in, day out? Alzheimer's drugs, the Leqembi, the one that is already supposed to be on market if FDA would actually cover it, is supposed to average approximately $26,500 a year. That would put it in the bottom 10% of cost for CMS, for drugs that CMS already covers for other major life-threatening illnesses. The per-person cost is actually remarkably low. Look, $26,500 is a lot of money for any individual family to bear. And that's why Medicare exists, so that individual families do not face this threat. Last half point. Veterans Health Administration is covering Leqembi already. CMS is not. The medical evidence, the scientific evidence is identical, but VA actually looked at the evidence and judged it to be appropriate. That is creating a situation in which, for example, my father, who was in the military for 2 years, if he had been alive when these drugs were available, he would have been covered. My mother, who paid into Medicare her whole working life, would not have been covered because she would have been under the CMS denial rather than the VA approval like my father.
All right, Dr. Tunis, we only have a few seconds left, but if we could just
Yes.
get your take on this.
My take is, and this is a good chance to plug my friends at Tufts who do these health economic models, and you can formally look at both the cost of a therapy as well as its near-term and long-term benefits in terms of, nursing home admissions avoided, et cetera. And there actually are methodologies for calculating a value-based price that, so I would say, yes, it's a good value, not necessarily at any price. And so I think, to engage in the discussion about how do we determine, at what price drugs provide the long-term benefits and savings and use that to inform what is a reasonable price. The one, hiccup in that is that Medicare famously doesn't have the ability to negotiate the launch price of drugs.
Right, right. Well, this has been such a great discussion. Thank you all for your time. Dr. Anna Burke, Ian Kremer, and Dr. Sean Tunis. Thank you all for being with us today.
Thank you.
Thanks to Julia, and again to our panel.